And she has been trying for pregnancy. And we want to proceed with this patient. So obviously her chief complaint is what?
infertility لأنه ما صار في pregnancy ولا مرة.
So this is according to the description, this is primary infertility. Yes?
Yes, because the conception has never taken place.
Yes, so this is primary infertility. She has never been pregnant before, neither miscarriage or any form of pregnancy. So this is primary infertility. So how would we proceed with the history? So the first thing we have to do is to validate our diagnosis. What do you mean by validating our diagnosis? Making sure that she is really primary infertility. So what's infertility? What's infertility? Somebody answer me.
الفيلير دكتور to conceive after 1 year of continuous unprotected intercourse.
Exactly. So this is what we mean by validating our diagnosis. We have to ask specifically that primary infertility, that it's involuntary failure to conceive within 12 months of regular unprotected intercourse. So every word in the diagnosis إلها معنى, which means that we have to make sure that the definition is met. So it's involuntary. So they have been trying. They are not using any form of contraception. They have been trying for pregnancy for 1 year, and they have regular, normal, unprotected intercourse, which means that they are not using any form of contraception, and the intercourse is happening at regular interval. What do you mean by regular interval? يعني it should be like a minimum of 2 to 3 times per week. So it's 2 to 3 times per week. You would be surprised قديش ممكن يكون في people seeking fertility treatment and they are not meeting the diagnosis. يعني they probably will not have regular intercourse, or they are being separated for a long time. أنا شفنا مرضى في العيادة they are looking for fertility treatment and they are living in 2 different countries. يعني تزوجوا بعديها الزوج مثلا مسافر في دولة أخرى وبيجي every 6 months or every 3 months for like a week or so, and this is obviously is not meeting the diagnosis. Okay. Clear? What? Clear? Okay. Now, the second point in the history is to look for the cause. Obviously انتوا في التكست بوك راح تلاقوا انه causes of infertility are so much. So different classification ناس ممكن يقسموهم hypothalamic, pituitary, ovarian, uterine, tubal, cervical, and so on. But from clinical practice, we can classify infertility causes into 3 categories: ovulatory causes, tubo-uterine causes. The third thing is male factor, and if nothing of this, we call it the unexplained or the idiopathic. So This is from the clinical point of view. طبعا لما تحكي على ovulatory, it will incorporate pituitary, hypothalamic, ovarian, thyroid, whatever causes. But the primary principle is that there is failure of ovulation. The simplest for patient to get pregnant, they should be ovulating regularly. The pathway, the tubes, and the uterus should be patent. There should be a normal seminal analysis and normal sperms, and that's what you need for pregnancy to happen. So if nothing of these three categories is there, then we call it idiopathic or unexplained infertility. Of course, there could be a combination of two or more factors. Yani, there could be an ovulation plus male factor. There could be a tube ovarian plus male factor. And that's what we call the combined causes. So in the ovulation, in the history, we have to ask questions, particularly just to know whether the patient is menstruating or not, is ovulating or not. And how would we check that? How would we check that?
We ask about the regularity of the menses.
So, detailed menstrual history. So periods are regular. Yani, the things that we have to ask in the menstrual history and to check for ovulation. Is the menstrual cycle regular? Is there any mid-cycle pain? Any mid-cycle spotting? Premenstrual symptoms? And primary dysmenorrhea. These are the 5 points which suggest ovulation. So patients who are having regular periods are 95% ovulatory. Patients with primary dysmenorrhea, they have some sort of pain in the few days, 2 to 3 days before the onset of the period, are ovulatory. Generally speaking, painful periods are ovulatory, and our painless periods are anovulatory. Mid-cycle pain, what we call it the Mittel-Schmerz pain, which is a mild pain at the middle of the cycle, and mid-cycle spotting, these two symptoms also suggest ovulation, and premenstrual symptoms also suggest ovulation. Premenstrual symptoms, I mean by that in the week leading to the menstruation, the patient will complain of headache, bloating sensation, breast engorgement, nervousness, change in the mood, and these are the symptoms, what we call it the premenstrual symptoms. So these are the 5 points in the history which suggest ovulation. So if the patient is having regular periods and they are painful, occasional premenstrual symptoms, this means that she is ovulating. Now, if we think that she is anovulating, then we will try to look for a cause. So what are the causes of anovulation? It starts from the top. That could be hypothalamic and pituitary. How would we ask about this? We would ask about headache, blurring of vision or double vision, looking for change in the vision, looking for pituitary adenomas. That could be hypothyroid symptoms, hypothyroid symptoms. That could be prolactinoma. So we would ask about galactorrhea and nipple discharge. Could be polycystic ovarian disease, and therefore we have to ask about hirsutism, acne, weight gain. These are the symptoms of polycystic ovarian syndrome. It could be premature ovarian failure, that the patient is having primary ovarian failure, and that means that she is going to have menopausal symptoms. So we'll ask about menopausal symptoms. So these are the anovulation. Of course, if she is taking any chronic medications that can affect the ovulation, like chemotherapy or radiotherapy. So you start by asking about menstrual history, looking for ovulation. If you think from the history that this patient is having irregular periods or painless periods, she is not ovulating, then we'll try to ask further questions to know what might be possible cause, and therefore asking about headache and change in the vision to look for pituitary causes, hypothyroid symptoms, prolactinoma symptoms, discharge, and galactorrhea, symptoms of polycystic ovarian disease like acne, hirsutism, excessive weight gain, symptoms of premature ovarian failure, and in particular the menopausal symptoms. So by this, you're making sure whether she is ovulating or not, and then you can check for a possible cause. Now, the next point is to ask about symptoms of tubo-ovarian disease, and particularly when you are talking about tubo-ovarian disease, you are looking particularly for tubal blockage, if there's any damage to the tubes. Now, that could be related to BID. So you ask about lower abdominal pain, abnormal vaginal discharge, if the patient has been hospitalized for pelvic inflammatory disease or has been treated for this. Could be adhesions. So you ask about pelvic surgery, ovarian cystectomy, or appendicectomy. That could be endometriosis. So you ask about deep dyspareunia and secondary dysmenorrhea. So these are the main three causes for the tubo blockage. Could be infection, could be previous pelvic surgery causing adhesions, or could be endometriosis. Of course, there are other rare causes that from the past medical history you might get. So, I mean, you might have immotile cilia syndrome if the patient is known to have bronchiectasis, or she has recurrent chest infection. If she's having cystic fibrosis, that could cause absence of the fallopian tubes. But these are rare causes, and then these will be obvious as well from the past medical history that the patient is having a chronic problem. But when you are talking about the ordinary patient, these are mainly the three main causes. So you ask about symptoms of pelvic inflammatory disease, which are lower abdominal pain, fever, abnormal discharge. She has been hospitalized for acute pelvic inflammatory disease. Has she had surgery in the pelvis like ovarian cystectomy or appendicectomy? Is she having any symptoms suggestive of endometriosis like dyspareunia, secondary dysmenorrhea, bleeding per rectum, premenstrual spotting? All these are symptoms of endometriosis. Any questions so far?
دكتور سؤال.
Yes.
هلا بتذكر بالمحاضرة كانوا حاكين إنه كمان بنسأل إذا كانت بتستخدم intrauterine devices إنه مشان الكونتراسبشن. هاي إلها علاقة بالتيوبال بيتنسين، ممكن تعمل لنا blockage أو إشي؟
Yes. Now, في هاي الحالة إحنا we are talking about primary fertility. So unlikely the patient is using IUCD. But if we are dealing with secondary infertility, then obviously IUCD will come here. IUCD can predispose to pelvic inflammatory disease. So it's a risk factor for pelvic inflammatory disease. So if she has used the IUCD previously, and that might have caused pelvic inflammatory disease and subsequently tubal damage. Yes.
تمام شكرا.
And with the male, then we moved into a male factors, and we ask about the health wise of the male, yani any medical illnesses. We ask about smoking, alcohol intake. We ask about previous inguinal surgery. So inguinal surgery like inguinal hernia, which has damaged, for example, the vas deferens, radiation, chemotherapy, infections, especially mumps infection and childhood infection, and of course the any medications. There are a lot of medications which can interfere with this spermatogenesis and the occupation. Do you know which occupations might affect the male parameters?
دكتور بعرف البيكرز لأنه بيكون الحرارة مرتفعة كثير فإنها بتتداخل مع السبيرم.
What else? الدرايفرز، هذول السواقين اللي بيضلوا يسوقوا على الخط مثلا فترات طويلة زي سائق مثلا نقليات أو سواق تاكسي أو كذا. For the same thing, they are sitting most of the time. There is increase in the scrotal temperature. زيها زي شغلة الفرن، نفس الإشي يعني. Okay. Now, medical illness, it's very important. They can affect the general health and the spermatogenesis. طبعا لأن explain there is nothing to ask about. It's by disease of exclusion. The other thing is you have to ask about coital problems. Coital problems, which means that you have to ask specifically if there are any problems during intercourse, like premature ejaculation, impotence, previous medical history like diabetes or neurological disease, which can affect the coital problem. Okay. So by this, you have validated the diagnosis. You ask questions about possible causes. It's very important to ask about previous investigations and treatment. Now, depending on the duration of this complaint, patient may have already visited somebody else and they have done some investigation or treatment. Now, these previous investigation and treatment are really very important because sometimes they can give you the clue to the diagnosis and give you an idea about what treatment they have received. For example, a patient, after you ask about previous investigation, ممكن they will tell you, yes, I have seen a doctor, for example, and they have done an X-ray for the tubes and they found that the tubes are blocked. So obviously that gives you the cause. I have done the hormonal profile and I have done the X-rays and male test and everything was normal. This is probably an unexplained infertility. I have tried, for example, ovulation induction, didn't work. So I wouldn't repeat it again if that's the case. They can give you, say, we have done seminal fluid analysis, it was abnormal, and so on. So this question is really very important, especially in patients who have a long period of complaint. You would obviously know that they probably have seen other doctors before you. Okay, any questions? Any questions so far?
ما أظن واضح دكتور.
Yes, okay. So this is really the how you proceed with the history. طبعا, of course, you complete the rest of the history, complete the history sections again. You ask about, obvious, past obstetric history, there is nothing. Past gynecological history, you almost ask about everything in the history of present illness. Past medical and surgical history, also you have already asked about important points. Family history, social and drug history, you have already also asked most of these questions in the history of present illness. So by this, you have probably completed the history taking. Okay, so these are really the very important component of quick taking history from a patient with primary infertility, concentrating on this important point. لسبب احنا, when we ask you, for example, in an OSCE exam or scenario, a patient like this who presented with 5 years or 3 years of primary infertility, what relevant questions you have to ask? These are the relevant questions. You have to validate the diagnosis. You have to ask about ovulatory problems. You have to ask about tube ovarian. You have to ask about male coital problem and previous investigation and treatment. Now, that will cover every single element in the history. Okay.
تمام.
Now, the next step, of course, you have to proceed for
Physical?
examination. Sorry?
Yes, doctor, physical examination.
So you proceed for physical examination. And physical examination, although you do a complete general examination, obviously you have to concentrate on these issues. So body mass index is really important. The symptoms or signs of hypothyroidism, signs of prolactinomas. You might have, if there's anything in the history suggestive, then you have to ask to examine the visual fields. For example, you will examine the breast looking for galactorrhea. You will see the body habitus and body mass index looking for acne, hirsutism as well. Then you proceed to abdominal examination, looking for tenderness or masses, vaginal examination and speculum examination, looking for the size of the uterus, mobility or tenderness, any signs suggestive of endometriosis. You might have to examine the male, and particularly the genitalia, looking for varicocele, for example, which might be detected during the examination. And by this, obviously, you have done the whole examination. So again, the examination is dictated by the history. You start looking for some signs which support your diagnosis. If you think there is something arising from the history, then you have to do specific examination for that area. Okay. Now, moving further, the next step would be to do the investigations. So the investigations are basically 3 types of investigation. Investigation for ovulation, investigations for the tubes and uterus, and then for male. So these are the 3 investigations that or the 3 areas that you have to cover them. So
دكتور بعد إذنك قبل ما نفوت بالانفستيجيشن باقي دقيقة ونص، إيش رأيك نسكر ونرجع نفتح مرة ثانية؟
Okay, that's fine.
تمام يعطيك العافية. هسه نسكر ونرجع نفتح.